and everybody over here accept that complications can result even in the best of hands. So only way to avoid complication is to avoid surgery. So what is our duty is to minimize the number of complications by making accurate diagnosis, correct treatment plan, and of course a skillful execution. So I will be dealing only with the complications of strabismus surgery as such. So I am not dealing with any anesthesia related or peribulbar related complications. So I will be covering this topic under perioperative complications, immediate postoperative as well as late postoperative. So perioperative complications, I need not emphasize that we should be very careful about the correct operating a correct patient, correct eye and correct muscles. It has to be double or triple checked before you start the surgery, and we need to have a good surgical anatomy. Sometimes you might have differences in the insertion and differences in the muscle position in cases of craniosynostosis and high myope, where you have to be very careful in hooking the correct muscle. So next most important complications which makes the surgery as such very little bit cumbersome is hemorrhage. So the sources of hemorrhage is basically conjunctival vessels as well as anterior ciliary vessels, and it is very common in resurgeries, vascularized and scarred conjunctiva, and of course dealing with adhesions in cases of resurgeries. And as already Ramakrishnan mentioned that we have to look for the presence of vortex vein. It is always better to isolate the vortex veins, identify the vortex vein, and then take it out of the view, so that instead of knowing exactly where the vortex vein is present, it is better not to touch the vortex veins. So sometimes you might miss the systemic diseases like blood dyscrasis, or patient is on aspirin therapy, particularly when you are doing squint surgery in older patients whom were cardiac patients. So how to avoid this? A careful and meticulous dissection as such will avoid bleeding in such cases, and gentle cautery can be used in the muscles sometimes, and then as I already mentioned, identification of vortex veins has to be done, and sometimes you might have to go for a bleeding time, clotting time when you suspect patients with blood dyscrasis, and when you operate a cardiac patient, it's better to stop aspirin before surgery at least for a week. So hemostasis is obtained by using phenylephrine, which is commonly done in most of the surgeons. But nowadays there are many papers demonstrating the effect of brimonidine even safer in children. 1 or 2 drops just before the surgery after the general anesthesia is given. It's relatively safer as well as controls the bleeding much better than the phenylephrine. So other advantages is it doesn't dilate the pupil, so that when you are operating adjustable suture techniques, it's always better to use a brimonidine, so that if you want to adjust the surgery immediately after post-operative, it helps. So next most common complication is globe perforation. As I went through the literature, there is a lot of varied incidents. Some studies shows 8 to 12%, some studies shows 4.3%, and one of the studies which has a larger numbers of 2,195 procedures showed only 0.68% of scleral penetration and no scleral perforation in such a large series. But still it happens sometimes. So it's more common with cases of high myopes and resurgeries, and particularly when you are dealing with restrictive strabismus. Sometimes, at least for the beginners, you can use this right grooved hook so that to avoid injury to the sclera while suturing the muscle. And in case if you suspect any perforation or something, you immediately call your help from the retina people, and then you can ask them to do a complete indirect ophthalmoscope. A simple perforation without any vitreous prolapse sometimes can be absorbed without any intervention. A large defect sometimes need suturing of the defect over the sclera, and sometimes they might have to go for a cryotherapy or a barrage laser over the perforated area. So next most complication, as Dr. Muralidhar has already dealt with, is detached muscle. It can occur in 2 scenarios. One, the muscle may slip off the sutures if you are a little bit careless in suturing, and sometimes there might be a muscle rupture or tear. So the basic thing to prevent detached muscle or lost muscle, to again stick on to the basics. You have to have a careful suture placement. The entire muscle should be included, and don't place the suture too near the end of the muscle. This might look very basic. Sometimes it might save you from the most important complication. Don't cut the muscle too close to the attached sutures, and ensure a good firm bites when suturing the muscle to the sclera. And if it happens on the table, immediately you need not panic. Immediately you have to follow a few steps to retrieve the muscle and suture it back. So you have to remember that do not pull on the Tenon's capsule, because pulling on the Tenon's capsule will make the muscle more retractable and it goes out of sight. And always do not pull the eye away from the detached muscle as you normally do in case of a normal squint surgery. When you suspect a lost muscle, you push against the opposite wall and backwards so that the muscle is exposed to some extent, so that you can just catch the muscle and bring it back to the original position. And when you are dissecting, always do dissect towards the apex of the orbit and never dissect along the line of the globe. That again will prevent the muscle from exposure. So the other complications which can occur in immediate post-operative is immediate undercorrection and overcorrection. Immediate undercorrection and overcorrection, unless it is a surprise for you, then you can just wait and observe till at least for 3 months after post-surgery, and then you can do any maneuver. Diplopia, slipped muscle, Dell suture, granuloma, all these things I will deal in the coming slides. So diplopia, it's always better to explain to the patient the chances of experiencing double vision for a few weeks post-operatively. Sit and talk to the patient before the surgery so that it is not a surprise for the patient. It might be a normal thing for the surgeon as such, but it might not be a surprise for the patient. They might get offended. So it is very common in the early post-operative period. As you all know that it settles down in 2 to 3 weeks time. So it's always better to leave it to settle spontaneously, either by suppression or adaptation to the situation. Sometimes when the patient doesn't take it easily, then he can even try for some patching or prisms for the time period, or even injection of Protax is sometimes needed. The slipped muscle is another one important complications that can occur in few scenarios where the failure of the sutures to include all the fibers of the muscle and only the capsule of the muscle is sutured. Here if you see, only the capsule is sutured and the muscle retracts back when the eye is moving. So it's better to go and then pull the muscle back and then have a firm suture. Sometimes if you are not careful in suturing the muscle to the sclera, sometimes it can slip. Because of one of the sutures can become disinserted, and sometimes very rarely both the sutures can get disinserted, and then it effectively works like a lost muscle, and it has to be managed as I said before. So Dellen is not very common. It is a small localized area of corneal thinning due to drying of the cornea. It is because of our improper closure of conjunctiva causing a small elevation so that the lubrication that is not maintained. So you need to sometimes patch the eye with the lubricating eye drops or a lubricating ointment, and then use a lot of lubricants, and routine steroids will help in managing this. This is one of my patients operated recently, had a suture granuloma, came back, eye is quite orthophoric, and then came back after 3 weeks with a redness and a small elevated mass like this, and then it is a suture granuloma. I just observed and increased the dosage of steroid and then waited. In another 2 months time it settled spontaneously. So sometimes if it remains back, you need to surgically excise the granuloma. So infection is very common right from conjunctivitis to the endophthalmitis. All are reported in literature. It can occur even in form of necrotizing scleritis as well as orbital cellulitis. When I went through the literature, all cases are reported atypical necrotizing scleritis, orbital cellulitis as well as endophthalmitis. So it is always, I need not emphasize that preoperative and postoperative antibiotics should be covered. So I'll just finish with this complication. Anterior segment ischemia has already been discussed. It is most important complication. It is because of the loss of anterior segment blood supply and the main risk factor being operating more than 2 recti muscle in the same sitting, and very common because we need to do a muscle transposition procedures in case of paralytic and restrictive strabismus nowadays. And you should always take care of the systemic associations as well. You have to get a clear history of diabetes, hypertension, or any other systemic associations where the patient has. This is one case which I have seen when I was a consultant in Aravind Hospital. So this is a traumatic 6th nerve palsy. Here if you see, there's a large esotropia, which is abduction is totally absent. So FDT is positive for left medial rectus contracture. So we went ahead and operated a medial rectus recession and a Hummelsheen procedure, partial tendon transposition with Foster's modification. So this was like, we are quite happy with the results. Eye is ortho on day 1, but as already Dr. Muralidhar showed, this was the picture. We had almost vision is reduced to 612, pupil was vertically oval, mid-dilated and non-reactive. Slit lamp showed a corneal edema, DM folds and AC reaction. Luckily the fundus was normal. So this is a very clear-cut case of an anterior segment ischemia following muscle transposition surgery. We went ahead with routine treatment with topical as well as systemic antibiotics and cycloplegics, and it resolved very well. I don't know why the pupil remained vertically oval. The picture which Muralidhar was also showing had a vertically oval pupil immediately after anti-segment ischemia.
Sphincter
yeah, I think except for that factor, everything settled and vision was 6.6 in the post-operative. So here if you see this is the post-operative picture where eye is orthophoric and some amount of abduction has been restored after Hammershim procedure. Quite surprising because this is a young patient, so we thought that even a partial tendon transposition will be harmless, but I don't know, retrospectively we went ahead and we just asked some history, then he said a history of smoking for more than 20 years, so that might be one of the reason for this procedure, I don't know. So it's always better to have a thorough systemic evaluation before going ahead with transposition procedures. There are a few things which has to be followed to prevent anti-segment ischemia. A thorough systemic evaluation, again I need to mention this. So you can avoid 3-muscle surgery by injecting a Botox injection into medial rectus instead of a recession, and a relatively partial tendon transposition like Jensen's and Hammershim is safer than the total tendon transposition, and whenever possible it is always ideal to do a vessel sparing technique, and incision, limbal incision, sometimes you need to do a 270 degree, more than 270 degree incision in case of muscle transposition. That itself sometimes leads to anti-segment ischemia, so it's preferably a medial lateral recession can be done under Fornix incision, and then always it's better to stage the procedure. Initially you can go ahead with the medial lateral recession and then wait for 2 to 3 months, and then you can go ahead with muscle transposition procedure. That sometimes helps. So I'll just conclude with this slide. A mistake is only a mistake if you don't learn something from it. So mistakes can happen to strabismologists. It's always better to learn from that and then to avoid in the near futures. Thank you.